Good evening. Welcome to tonight's American Shoulder and Elbows Virtual Fellows Series. This is a practice management series, which is under the auspices and guidance of Dr. Mark Frankel, immediate past President Bill Levine, and President-elect Javier Duralde. I, along with Samar Hassan, are the education chairs and will be manning the chat room for tonight's session. It will be moderated by our President-elect Javier Duralde. The panelists will be Edward Spencer, Randall Otto, and Ian Byram. Dr. Duralde.
Thanks, Ron John. It's my pleasure to be here today, and it's my pleasure to host this webinar. Let me just get my screen up here with these fine surgeons in the Shoulder Society. And so our topic tonight is going to be marketing yourself as a shoulder and elbow surgeon. And this is yet another topic and another area of your practice, which is extremely important in terms of the business of medicine, but which you get no training in throughout medical school, residency, or fellowship. And yet when you get to practice, it's something that's important for you to do and know about. And so hopefully you'll be able to glean some important information from the panel tonight. So what's the purpose of marketing? Well, you want to identify yourself as a shoulder and elbow surgeon. You've gone to all this trouble doing the extra fellowship, getting those extra skills, putting up with those overbearing attendings and professors so you can get to where you are. And you certainly want to be able to use those skills when you get there. But if you don't get the patients, you're not going to be able to use your skills. So to whom should you be marketing yourself? Well, there's all kinds of people that are important for your referrals. So those include patients, your own partners, local and regional physicians, employers, and insurance companies. All these people control the flow of patients to your office. And it's very important to include all of them in terms of your marketing plans. And the way you do that is really unique to each of these different groups and can be different region to region, depending on competition and things like that. So how do you do it? What are your options? Well, there's word of mouth, which is the old traditional way. We did it years and years ago. Internet and social media now are much more important and play a bigger role. And certainly the old traditional radio, TV, and billboards, and then didactic presentation, something you guys are all used to doing constantly throughout your education and training. And these can be done to a number of groups, other physicians in your hospital, physician groups in town, such as primary care groups, physical therapists, and then even medical societies in your area, locally, regionally, and even nationally, all the things that kind of help you develop a reputation so patients will send you, people will send you patients. Now, marketing is controversial. When you ask yourself, well, is this professional or is there a sleaze aspect to it? Am I going to be the guy on the side of the bus or the back of the phone book? And then is it effective? And how do you figure out whether it's worth the cost of investment? Because it's a lot of money people spend. And so you say, well, how much money do people spend on this anyway? Well, if you look at the Orthopedic Forum, which is a group of about 4 or 5 large groups of, there's about 100 groups of 20 physicians in each group, so about 2,000 doctors, and so this is pretty good data. And those large groups of 20 or more men spend about $500,000 a year on marketing. That's a lot of money, and if you break it down per person, it's about $19,000 that comes out of each doctor's pocket to market themselves. And so obviously, these groups think it's important. Now, what do you spend that money on? Well, this is just sort of a ledger out of our own group, and you can see all kinds of different things, meals, promotional gifts, FTEs, sporting things, from professional sports to high school sports and college sports, and use of athletic trainers, which you can give to high schools. And so all kinds of different things that you can use, a variety of ways that you can market yourself. So I'm lucky enough to host this panel today, and I'm being joined by Edwin Spencer from Knoxville. And here I've appropriately taken people's web pages, which is part of their marketing schemes. And then Ian Byram from the Nashville area, and Randy Otto from St. Louis. And so hopefully in the next hour, the 4 of us will be able to go through a lot of question answers um, and discuss the important themes of marketing, and hopefully give you a better idea by the end of the evening in terms of what you can do to help market yourself. So let's go ahead and start with sort of the basic question. What is it that people should be doing initially? The first things they should do when they get into practice to start to market themselves as shoulder elbow surgeons. Ian, why don't you take that one?
So, we had discussed this amongst ourselves, and there's a lot of different ways you can go about it. And one way that I initially started was marketing within my own group or your practice or academic institution, if that's the case. And ultimately, what you have to be willing to do is to accept anything that involves the shoulder and the elbow that your partners don't really want to deal with. And that's one way to start, is to just be an open door. And even if they say, hey, can you just help me with this case, go and help them. I mean, you're not that busy to begin with anyway. You may have time to do that, whereas later in your practice, you may not. And along those same lines, basically, you kind of have to be willing to give some things up. And if you have a partner, for example, who is a sports partner who may be willing to send you more of their shoulder arthroplasty, if you're willing to give up some lower extremity sports cases that you may feel very capable or willing to do, it creates a bit of a trading between yourselves. And I think that helps you build your niche so that they're more willing to send cases to you within your own group.
That's great. And Ed, how about you? What about like physical therapists in your area? Is that an important group to get in touch with?
I think the physical therapists are one of the most important groups, because those are the guys that are they're on the kind of front lines. The primary care doctors are referring to the physical therapists, and the physical therapists are the ones that are in their ear. They're seeing them 1, 2, 3 times a week. And so then you'll have, and you give them direct access to your practice, that you will have a great funnel of patients. And what goes along with that as well is giving local talks, local just information where you can go and talk to the therapist, or you put on just a local conference and you invite the therapist and local orthopedist. That goes a long way as being a local expert. And I give all the therapists my personal cell phone number, and then also my nurse. And so they can get in direct contact with me whenever they need to get in touch with me. Hey, I've got this athlete. Hey, I've got this person. This guy's struggling with a rotator cuff tear, and they'll send them right in. And then you have to get those patients right back to them as well. So it's a two-way street.
So Randy, it's a bit of a challenge. You go to a group and you're the new guy, and you've learned all the latest techniques, and you really feel like, okay, I'm cutting edge here. And yet you get to your group and there's 2 or 3 guys who have the reputation of being the shoulder guys in town. How do you walk that minefield of not trying to be too uppity to start with, and yet integrate yourself in a way that you can start getting some of those referrals?
Yeah, I mean, I think like Ian had said, is that you have to be able to market yourself within your group and offer with them. You got to network with those people. In St. Louis, I'm working at one university, and there's a huge university of WashU physicians in town. So we collaborate together, and we started a society in Missouri, the Missouri Shoulder and Elbow Society, so that we can bounce ideas off of one another. And it's not so that we can compete with one another over it, but it's so that we can learn from each other and try to help the community out as a whole with it.
How often do you guys get together?
Well, we do annual meetings, and then we used to do some different things. COVID has kind of put a stop to a lot of it, but we would have an annual meeting, and then we would try to do quarterly get-togethers with it as well.
Great. That's great. So Ian, traditionally, it was the primary care physicians that controlled the referrals. And back in the day, you want to make sure that you met the primary care physician, family practice, and the internist. How does that fit into today? How important is marketing to that group?
Yeah, I think that plays a big role, especially if you are out in the community and you don't have an academic institution name linked to you. I think it's even more important. And there's multiple ways you can do that. Kind of as Spence was saying, you can arrange talks and just basically show up at their office and beat the pavement a little bit. The other way is by word of mouth to the patient. So if you see a patient that was that you know is followed by a primary care physician, you end up operating on that patient, sending copies of your notes to the primary care physician, and just giving them your cell phone number. Being accessible to other physicians and therapists goes a long way. And so the way medicine seems to be happening here in Middle Tennessee is there's a lot of these outside area urgent care centers. And so if you can find the people that are running those, and then they call you when they can't interpret an x-ray, and then that automatically gets you a connection there, and they're more likely to call you the first time.
I think that brings up a couple of good points. One is you want to be available, right? You don't want to have somebody call and say, well, it's going to be 2 weeks to get that patient in. If it's somebody that you're trying to get these referrals from, you got to get them in that day or the next day and be available. So oftentimes when you start your practice, you may want to do an office half day a week, every day of the week, just to be available in the office every day, because you're not going to be operating right away. The other is you got to get your notes done and sent back to them in a timely manner, because they're going to be collecting all these records to manage the patients for their other health issues. You got to make sure that you get your notes done and sent over.
That's great. That's great. Now, blogging, social media, those sort of things, those didn't exist, 30 years ago, 20 years ago, we went into practice. But it seems like nowadays that those activities are extremely important. So, you ask yourself, well, who's got time for that? And how do you do it? Spence, why don't you tell us how you use that and how you find time to get it all done?
I lost a little bit of internet connection there. Hopefully I'm back on. But to go off what Randy and Ian were saying, it's access and availability. So that's where a PA or a physician extender can come in handy. So the primary care physicians, what they really hate is waiting online saying, okay, I want to get this patient over to see Dr. Byram. And then his nurse or her nurse is waiting on the phone for a long time. It takes them forever to get in and see Dr. Byram. If they have your nurse's direct number, hey, I can get you in today, I can get you in tomorrow, I can get you in this week, and they've got that direct number, that's the communication that you have to establish, because it is onerous for those guys to send patients in. Make it so that it's not onerous. Now, Javier, your question, I'm sorry, I missed the front end of that. Was that how you manage all these patients, or what was that? I'm sorry.
No, it had to do with social media, kind of shifting gears now, and how
Okay.
media nowadays playing a larger and larger role in our ability to put ourselves out there. I mean, obviously you guys all have your websites, and part of that's blogging, part of it's videos. Tell us sort of how your plan of attack there and how you manage to keep all that up to date.
Okay. Yeah. So that's where my research assistant comes in handy, because that's one of his responsibilities, is to man the website. Any questions that come in that we can blog on, I'll blog, and I'll blog through him, and he manages those. Any requests that come in for an appointment, he and the nurse take those calls and take those emails and get them in right away, and then make sure that they check it every day. And so you have to get extenders of your own practice to do that, whether it's a physician extender as a PA, nurse practitioner, or research assistant. You've got to be able to do that, because you can't do it all.
And do those people help you create material too to put on there?
Oh, absolutely. Because when you get like me, you've got gray hair, you're not as good at doing all this computer stuff. And so you've got to get some of these younger guys that are so much better at doing this stuff. But yeah, you've got to get these guys to create websites and create excitement so that people will come to your website, increase how many numbers are actually seeing your website, so it comes on first as soon as they start doing searches and things like that.
Ian, what kind of material do you put on your website with your social media things to try and help your marketing efforts?
So really, whenever we are either out in the community covering, so I cover a couple of high school sports teams. So in your case, or those who cover professional or collegiate, anytime that you can be on the sideline and get a picture, you can either tweet or put that on Facebook. And that's an active engagement that a lot of our patients do enjoy. Similarly, if I'm giving a talk at a meeting, or participating in a lab, or doing something for education within shoulder and elbow, I'll always post that, and I'll have a list of those on my website. And I've been pleasantly surprised by how many patients follow that and ask about it at their appointment. And ultimately, you have to kind of advertise for yourself. And Randy mentioned it earlier, collaborating with other people. This is a way to actually grow, increase the pie. You want people to come to a shoulder and elbow specialist. So you may have several others in town, but you want them to come to one of you, and building each other up helps you in the community. And I've been fortunate to have other colleagues in my community that do the same thing. So kind of two questions in one there.
I think in building your website and getting noticed online, you have to have somebody to help you with that, because there are going to be certain keywords when a patient goes to look up shoulder surgeon Knoxville, right? Shoulder surgeon Nashville, shoulder surgeon St. Louis. You want to have your name pop up on that web page. And so whether you work at a university like I do now, where I have marketing teams that can do that and they know how to do that, or if you're out on your own, work with a web company, because they're going to know how to do that. You check off the list of the different buzzwords that you want: a shoulder arthroplasty, reverse shoulder replacement, whatever it may be that you want to target, so that that's going to move up the ladder on the Google search.
Now we did something similar in Atlanta years ago, because we found that each one of us who was a shoulder specialist within our group had nobody to ask questions of, because if you didn't know the answer, none of your partners knew the answer either. And we would get together like on a quarterly basis, just have one of the reps bring pizza, and we just bring x-rays and just flip them up, and what will you do for this, what will you do for that? And it really developed a great esprit de corps among shoulder specialists in Atlanta. And it also helped us because you were less likely to badmouth people, and we were all seeing each other's second opinions, So if you were seeing a patient and you expressed to them that you knew Dr. So-and-so personally, it made a difference. I think it really helped the whole way we practice medicine. So I think that's a fantastic idea. But so Ian, so you're the new guy in town, you're a shoulder specialist. You've obviously done stuff to try and get your partners to know what you can do and know your skill set. How do you translate that out to your local community and your region and your state? How do you do that in a tasteful, non-threatening fashion, marketing yourself to all those other orthopedic surgeons to let them know that you're an asset that they can use?
Yeah, so one is availability, as Spence mentioned also again, always being available, and then being as collegial and open to your colleagues as possible. I mean, we all have complications and we all have disasters. And when someone calls you, I think, I can't remember who once told me this, but when someone asks for your help, they probably need it. And when they call and ask you for help, you should be as positive and encouraging, and then give them feedback afterwards. And I've had the opportunity to meet some other surgeons in that method. And it's just about being positive. You're never going to get anywhere by bad-mouthing your competition, and then being available. And then, to Spence's point and yours also about primary care, just getting out there, whether it's doesn't have to be some shoulder society meeting that you're speaking at. I mean, you can find the Silver Sneakers group at the local YMCA. You can be involved in community events. And just being a part of your community will eventually percolate through. It just takes a little bit of time.
So Spence, what about giving lectures? Like you want to get on the lecture circuit as soon as you can. You've got material from your fellowship. How do you do that? How do you start getting on the podium in places like in your city, in your state, nationally? What do you recommend for that?
We did one when I first got to practice, and it was a bit of a struggle. We had to get sponsorship from industry, and that's a little bit tougher to do now than it was back then, but even then to try to garner as much money as you could. But you can do it in collaboration with your partners. You can do it in collaboration with the physical therapist. And then whatever companies that you work with will be willing to sponsor that to some degree. You just have to submit it and go through a little bit more red tape right now. But I think it's worthwhile to work within the community like that. And then some of the low hanging fruit that you have to understand is that the inpatient or the in-room marketing is something that can't be underestimated, or it should be really appreciated. So when that patient's in your room, when they leave, they should get a folder that says, you know, everything about Randy Otto and what you do. So you open up the folder, you've got a brochure about what you do, reference to your website, a card with your face on it that has a QR code on it that takes them right to your website, so that as soon as they hit that, again, your website comes up. Now it's going to be more popular. But that in-room marketing is huge. And then I started making videos for all the arthroscopies that we do. And so if I'm doing Ian's surgery, I'm going to be talking to him. Ian, here we are inside your shoulder. This is what it looks like, blah, blah, blah. And I'm showing him how we do his rotator cuff repair. He shows that to his family. He shows that to his physical therapist. So use your patient, leverage that time that you have with the patient that costs nothing. It costs nothing. And then you've got these folders that cost a little bit, maybe a flash drive that costs a little bit, but use that ROI is going to be huge. And so don't underestimate that in-room marketing that you can do right there.
And Spence, to piggyback on that a little bit, early in practice, I used to have sort of these things, these little kind of holders of files in the room that you could see. And I would put my research articles and I would highlight my name in the title. And a lot of them had to do with things that patients are interested in. It's sports or baseball or shoulder replacement. And then they see that you're an expert and they're sitting there waiting on you. What else are they going to read? I mean, it's better to have that than Southern Living or some other, garbage sitting around the office. So it's a subtle self-promotion, but it gets you a little bit of respect.
Question for the group from one of the panelists, from one of the attendees. So how do you, as an ASES trained shoulder surgeon, separate yourself from hand or sports trained surgeons who market themselves as shoulder specialists, but yet do not dedicate their entire practice to shoulder surgery?
All right, Randy, you want to take that one?
Sure. I mean, I think if you want to be a shoulder surgeon, the first thing you have to do is you have to say, I want to be a shoulder surgeon. And the day that you start taking everything into your office, the harder it's going to be for you to become a shoulder surgeon. So that's number one. And that may be hard initially because you want to just try to get busy and you may see that foot pain or knee pain or hip pain. But if you want to separate yourself and truly be a shoulder surgeon, then you have to do that. And for me, what I wanted is to be a shoulder arthroplasty surgeon because that seemed to be a bigger difference as a shoulder reconstruction guy than doing labrums and rotator cuffs. Now they're going to come with it. And so I just take shoulder of all ages and it's kind of morphed into more of a shoulder replacement thing. But I think if you want to do shoulder, you sometimes just have to say, listen, this is what I'm going to do. And I'm not going to see these other problems in my clinic off the bat, even if you're going to be slower to start.
Spence, you have anything to add to that?
No, not really. I mean, I think you just have to be willing to take on all shoulder cases. Yeah, I agree with Randy that you at some point you have to differentiate yourself and just say, yeah, I'm just going to do straight shoulder. But you have to be willing to do it all. A little bit different. I like to do everything. I love cuff and I love instability and arthroplasty as much as I love anything else. So
Yeah, I think, everybody's going to pick their focus. If you look at what the sports guys do, the hand guys do, probably the area where we separate ourselves most is with arthroplasty, revision, and probably bad fractures, and everybody overlaps with us somewhere, but those are the areas we sort of own more than anybody else, and I would say that the way you separate yourself is by accepting the horrible cases in your town. because if you take the bad ones, the good ones will follow. And you have to realize that the type of, if you're a sports medicine doctor, if the patient didn't return to previous level of play, failure. Well, when you think like a shoulder arthroplasty surgeon or a shoulder reconstructive surgeon, if you can take a poor result and turn it into a fair result, that patient is often one of the most happy patients you'll ever see in your office. And you have to be satisfied that there's certain that you can, or amounts that you can help people, and you do what you can. And if you take the really horrible cases, I think that's how you're going to distinguish yourself from the other surgeons who aren't willing to do those.
And one other thing that I'd like to add to that is that by virtue of watching this panel right now, I think anybody that's watching is taking the first step. It's getting involved in the Shoulder and Elbow Society, because every day I get, an email that says, "Hey, I've got a guy," and they name a random city. Do you know anybody there? And being involved in the Shoulder and Elbow Society allows you to build a network of collegiality with other shoulder specialists. And I think that goes a long way. You're not just a part of a group of orthopedic surgeons, you're part of shoulder specialists. So.
That's very well said. It's extremely true. In the last couple of weeks, I can't tell you how many referrals I've gotten from other parts of the country just because I'm the guy people know, through the Shoulder Society. All right.
Another question for the group from one of the fellows. For those of you who pay out of pocket for professional websites, how much do these cost, and is it worth it to you? Or does your university or your practice website profile sufficient?
Let me field that one. So one of my partners he paid a professional group to do his website, but I was able to make a really nice website, and I think it was only $350 to get that, to get the professional licensure for that WordPress. And so he did a great website, but he's a 25-year-old guy and that's what he loves doing. So if you can find someone to do that, it doesn't cost that much, as opposed to what my partner paid, which was $5,000 and $1,000 every month.
Right. If you have the time, all you need is a host to do it, and you can build it however you want. My wife has her own private practice and did the same thing, and she paid negligible amount and basically just has a host that manages that, so that if there's some spam or somebody tries to steal the log into the website from like a gaming system or something, that it blocks that. But she designed the whole thing, put all the pictures, type all your stuff. So you can do that pretty cheap. You just got to take the time to actually do it. Where the challenge is are you going to be noticed in that whenever somebody goes to Google it? So that's where you may want to have some help, or at least get some education as to how can I set this up so that if somebody goes and types in a name about shoulder, that this website's going to pop up.
That's where the blogging comes in. That's where my research guy goes on, and at least 4 or 5 times a week, he's hitting that and making sure that people are responding. So every time he hits it, they hit it. It goes up, and so it goes up higher in the ranking.
So I'm going to actually respond as well, if you don't mind. I've done it both ways. The difference when you do it by yourself, you got to spend the sweat equity to update your site on a regular basis, and you got to spend the time to do the blogging, just like you said, Ed. And if you're willing to do that, then it works out fine. But once you start getting busy, it's pretty hard to do that. If you want the same flow coming, a professional management site can be worth it. And it's usually about $5,000.
And I would also, just to the second half of the question about your university or practice website being enough. If you're at a university, so when in my initial practice was a part of an academic institution, they actually have certain regulations and they will limit your website. So you have to be careful before you go pay someone a lot of money. Make sure that you're not going to waste that money if your university doesn't allow you to do that and manage it on your own. And then if you don't have a budget for it and you don't have a marketing committee who's going to do it for you, another way to kind of get onto the internet is through Facebook or Twitter. And you don't really have to have an active content. You can literally just, as things happen, you can do a 2-word post with a picture and it engages people. And And amazingly, a lot of patients, even elderly patients, are on Facebook. I would say that Facebook hits, and we look at this within our marketing committee, because we have professional Facebook and Twitter accounts. I don't have a personal one. Those are much higher yield than Twitter, for what it's worth, amongst the average patient population.
Well, that's a great segue to talk about differences between the academic practice and a private practice. And so we have the benefit of having on this panel Ian, who went from an academic practice to a private practice, and then Randy, who did the opposite, went from private practice into an academic. So let's start with Randy. So what do you see as differences in terms of how you would market yourself in private practice versus a teaching institution?
I mean, from a private practice standpoint, it depends on how much you have to do personally versus how much you share as a group. And so if you have a good, strong group and everybody is equally sharing into building up a good website, then that's helpful. If it's a group to where you're all individuals and kind of responsible for your own thing, then you're going to have to just go out and run with it and pay the money to get your own website. But if you have a group that's big enough, and the group that I was in was actually in the Orthopedic Forum, they're going to have a marketing budget. And so collectively as a group, then you have to decide how you're going to do that. Now you can still get your own personal website, but with that, you're going to have to link it to the group's website with it. As overhead goes up, then sometimes that marketing dollars go down. So, so you have to play with that as well, which makes it more challenging. Being in academics, I basically just went to them. I looked at their website and I said, this is what I want. And you got a little more to play with, but because they have more of a budget for the marketing. And so since I've been, switching over to the academic side of things, I've had a lot more introduction into news and newspaper articles and magazines and things of that nature. They've set up more lectures with the hospitals and then got me in front of some additional physician groups that I didn't have before. So it's been a good thing from that standpoint, from an academic standpoint, but you're not gonna have as much stay in it either. If you're private practice, you have a lot more single-handed stay with it.
Yeah, I mean, I think those are great points on both sides of the coin. Sometimes in an academic setting, it's a network of physicians that already exists. So all the primary care physicians may work for the same hospital, and then they create an automatic referral network. Whereas you have to probably hit the pavement a bit more in private practice to get to know some of the physicians, and it may not come across your doorstep as easily. On the other side of the coin, you can be a bit more nimble in private practice. You don't have to run things through different administrators, and you don't have to go all the way up the chain to get marketing dollars changed. So I would take advantage of that if you're in the private practice setting. I mean, you don't have regulations, so you can decide how you want to appropriate your web content or time. So it can certainly be done either way. And you just have to be persistent in either method. So
it's a great point. I think either a well-known group or certainly a well-known academic institution is going to be a draw for patients and is going to have a network of referring private practice physicians. But no matter where you go, you need to differentiate yourself and distinguish yourself within that institution. And you really need to make an active effort, not expect someone to do all this stuff for you. So you need to sort of be able to create an individual out there so people can differentiate you from other people. So, we hear about sports teams a lot and how sports can help you. And, you see the different advertisements going on in the sports arenas and even high school stadiums and stuff like that. So let's talk about that in terms of how you use that and whether it's worth the money and the time and effort involved with it. Spence, why don't you start with that and tell us about what you've done with sports teams and whether you think that's worth it or not and how that's benefited your practice.
It depends on the practice that you want. Obviously, Randy wants more of an adult reconstructive practice, and I enjoy that. I enjoy doing arthroplasty, but I enjoy being on the sidelines. And so paying for athletic trainers makes a big difference because not only do you get the student athlete, but you also get the moms and dads that are in the stadiums. It's fun. I enjoy being in the training room. I enjoy having time on the sidelines and on the court. So paying for athletic trainers, I think, is a really good investment if that's the kind of practice you want to, if that's the kind of practice you wanted to develop and cultivate. So it depends on how you want to go and what you really enjoy. So I enjoy all facets of it, but I probably enjoy that as much as anything. Seeing the young athletes on the sidelines, I'm sure you guys like that as well. I mean, the smell of the grass, just getting out there. I mean, it's just fun, and I enjoy that. So you shown a chart earlier, Javier, where you'd spent money on athletic trainers. That's a good expenditure of money, not for the student athletes, but for everyone else too.
Yeah, I think so. And I think that one very good point you just made is you have to enjoy your job, So there's a lot of different options you can do, but you want to do things that you enjoy doing, because at the end of the day, we're busy, we work all the time. And so you want to enjoy what you're doing. Ian, what do you think about the level of team, like high school versus college versus professional? What are the advantages, disadvantages of each of those levels?
Well, everyone that trains at, under people like you or any of our fellowships, and you come out and you're taking care of your mentors are taking care of professional athletes or collegiate athletes, you come out and oftentimes those teams aren't asking you to take care of them. And so I started at the high school level. And I'll tell you that as far as bang for your buck, the time that you spend on Friday nights at a football game, you're going to meet more families. You take care of the kids, and then you see grandma when she, injures herself. And I think that from a community building standpoint, taking care of a high school is absolutely worth it and extremely helpful. And, if you aspire to take care of a collegiate or a professional team, that's fantastic. And I think that'll help you from a marketing standpoint as far as name recognition on a, if somebody doesn't know you. But as far as a grassroots growth, you're going to get more out of taking care of a high school or even a multi-level. There's these academies that are K to 12. All of a sudden, you're taking care of all 3 kids and their parents, all from a single connection on a sideline.
Question for the group.
There's also baseball and football.
Yeah.
We get back to sports. Okay, what's the question for the group?
How important, from one of the fellows, how important or helpful does the panelists think about taking general or trauma call to building your referral network within your community early on in your practice? Specifically, how does a young shoulder surgeon balance the benefits of taking on general orthopedic cases against the imperative of presenting yourself as a shoulder specialist earlier in your career?
Randy, why don't you take that one?
But one of the things that you have to be aware of is the community that you actually get to practice in. For instance, St. Louis, it is mandatory to take call. They don't pay for call. If you're on staff at the hospital, you have to take call. So it sucks. There's no option. There's no different thing. So whereas most of the other areas of the United States, you get paid for call, you do it if you want to do it or not. So what I would say to balance it is you get in good with your hip guys and say, listen, any of these upper extremity fractures that come in that you don't want to take care of, because none of them want to take care of proximal humerus fractures or distal humerus fractures, you give me those and I'll give you the lower extremity things that I don't want to do, and if you can get some referral base, even if it's okay, I got to come in and put an X-fix on, but I have a guy to shuttle this tibial plateau over to, then you do that. So you can still do that early on and still distinguish yourself as a shoulder or an upper extremity surgeon by trying to take on those more challenging proximal humerus fractures or distal humerus fractures and get rid of the lower extremity stuff.
Ian, what are your thoughts about trauma early in your career? Is that helpful for you as a surgeon?
Yeah, I mean, I think it's helpful for a lot of reasons. One, you're taking call. I mean, if you come in as the new partner in a group or an academic institution and don't show interest in doing some of the hard work in the trenches, that doesn't come across the right way. And then you take care of the things you can take care of. And some of those cases can even be good sort of, collegiality building experiences. You get an easy bimal that comes in that's treated as an outpatient. Well, you call up your foot and ankle partner and he sees that you're giving him an easy case the following Monday, then he's more likely to call you when he has a clavicle fracture instead of just plating it himself, because both of you can do those cases. They're not that challenging. And then if it's kind of a night of thing, to your point, you're probably becoming a better surgeon just by treating trauma. And so I think it's essential. Now, you do have to, over time, you kind of weed it out and refer to your partners. And but early on, I think it's essential.
Spence, anything to add to that?
No, I think Ian's comment about actually getting in, rolling up your sleeves and showing your partners that you're willing to do the hard work, that's the most important thing. Whether you get a case out of it or not, you just have to show that you're a team player and that whenever you're called in, you're there.
And you got to play for the long haul. So you fix grandma's hip one year, next year you're replacing her son's shoulder or fixing granddaughter's labrum. So you got to be in this for the long haul. You're trying to capture families and generations, and you do that by taking call early in your practice.
One other point on that I'd say is that even when you're not on call, make yourself available to your partners. So, if you've got another guy who's taking general call and he's maybe not as comfortable with a proximal humerus fracture yet, for whatever reason he's doing it that night, you say, hey, feel free to call me. I'll come in and give you a hand. And that goes a long way.
So I think you've heard the availability issue about 10 times tonight. It's the 3 A's of being a good doctor in order of importance, availability, affability, and ability. And that there's nothing that's been said that's more true than that. And I really think that with difficult trauma, proximal humeral trauma, you cut your eye teeth. I mean, that's what Evan Flaty said. You cut your eye teeth on that surgery, and you really learn a lot of tricks in that help you later on in other types of operations around the shoulder, because they are very challenging, and you grow as a surgeon when you're doing it. This also begs the question of how busy you get doing shoulders right away. So people are saying, well, should I be doing the hip and the ankle and whatever? Well, it seems like it's better than twiddling your thumbs. So what do you think is a normal or a reasonable time frame for growing a shoulder and elbow practice? So Ian, you arrive at your practice, you just freshly minted from your fellowship. How soon do you think is reasonable to expect that you're going to be doing almost all shoulder and elbow?
So I think this is a critical point for any of the fellows listening in right now, because you don't want to be disheartened or frustrated. It does not happen immediately in most cases. You might have a certain situation at an institution where it could work, but for me personally, it was, thinking about it and tallying up the cases, it was 5 to 8 years. And I mean, I'm in year 9 right now. So it's not like it's been this way for 5 years already for me. And not being frustrated by that, I think is important, and just know that you're doing the best you can to subspecialize and build your practice and do the right thing. And it will come. And it really kind of hits a snowball period. I think right around 5 years is when it really ramped up for me in particular.
Randy, what was your experience?
Yeah, I think it's a similar thing. I think part of it depends on the group that you're in. If it's a smaller group with 4 or 5 guys, then everybody's going to be kind of working to try to make some dough and pay for the overhead. If you have a larger group, mostly subspecialists, then you may be able to get into that earlier, but you're still going to have to do the trauma call. You're still going to have to do everything else, and you're still going to have other partners who are going to do rotator cuff repairs or may do some basic shoulder replacements. And so it'll take time for that to develop, and that's part of that reason. If you take the shit and you take the bad cases, then eventually those easy cases will come, but it's going to take some time for that. So it's at least 5 years before you're really getting into that, and that would be a kind of an early estimate, but it's probably 5 to 7 in most cases.
So I got to Atlanta in 1993, and there was no one here who was doing a shoulder practice. And when I interviewed at the university, they said, well, you could either be an arthroplasty surgeon or a sports surgeon. Those were your 2 options. But being a shoulder surgeon was sort of a square peg in a round hole. And so it took me 7 years really before I was doing nothing but shoulder. Just kind of, part of it was going out there and doing the marketing, giving the talks, accepting those terrible patients, And I like Randy's term. I think you ask most people in the shoulder society, and they'll describe their practice as the shit shoulder service, because you just get everybody's terrible cases from around the region. But that's how you really develop the practice. And so I think you just have to keep bread on the table, so keep your schedule full, do whatever you have to do, but keep pushing towards the focus in shoulder, so that you eventually start fine tuning it to where you're more and more shoulder, and then that's all you see after that. And so I started excluding different types of patients as I got busier. And when I got to the point where I was seeing enough shoulders, I'd give up doing knee scopes, things like that, kind of pushing things out of the way. So you got to stay busy, because I think, you're going to learn more as a surgeon by being busy operating, no matter what body part you're at. Spence, what was your experience in Knoxville?
Well, we're really subspecialized, and so I kind of stepped into a practice where I could do just shoulder and elbow, but I used to do a lot more elbow. Now it's just exclusively shoulder. I think 5 years is pretty reasonable, but we've got a lot. It's very subspecialized, and so here it wasn't as hard to get as busy as quickly as others. I think I was just fortunate and blessed to get into a situation like this. But I think what they're saying, 5 to 7 years, is pretty reasonable in most places.
Yeah, and my practice has evolved. I did all the terrible elbow trauma when I got here, and then thank God we got some guys that like to do that later, and I could start passing those cases along. So
Amen.
it's an evolution.
Hey, Javier, can I just make one comment?
Yes.
I love to share this. When Chris Ahmad started at Columbia, he used to cover a hospital in New Jersey where he was taking care of infected total knees. So I use that as an example because I think fellows get used to seeing their mentors with these unbelievably finely contoured practices that you guys just heard tonight have all taken 5 to 7 or 8 years, sometimes even longer. And so, you don't walk into your practice typically and have 150 total shoulders waiting for you like you saw during your fellowship. So just remember, infected, pussed out total knees, Dr. Christopher Ahmad, the world's most famous Tommy John surgeon now. Love that.
There you go. That's a great story, Bill. Thanks for sharing that. So, Ranjan, any other questions?
Before you go on,
Yeah.
one of the fellows said that she would like to hear from Dr. Otto and about the transition from private practice to academics and what prompted this. Also curious how those in private practice on the panel have been able to efficiently do research without all the resources, personnel that academic university-based practice have access to.
So yes, I'll a little bit on my background. So I was in a private practice group and built up a practice over about 8 years in that period. And during that time, I did my fellowship with Mark Frankel, and so I got a sense of what you could do as a private practice academic surgeon. So I got involved with the university right away. I was an adjunct assistant professor at St. Louis University, so I did have residents rotate through, but I built up a big shoulder practice over the time that I was there, and I got busy. And there were 3 things that kind of prompted me to switch. One is the call got to be too burdensome. It was too much trauma call. By that point, 8 years later, I had a huge busy practice, but it was a requirement for me to continue to take trauma call, and I couldn't offload it, and I couldn't get my partners to help to do anything to change it. So physician burnout is a thing. There were too many days that I was getting home late and I missed dinner with the kids. Then on top of that is the business that I was in was not very good. So once you're in a group, you really have to understand the business side of things and get to learn it, because overhead is a real thing and you got to know who's managing the money and how they're doing things. And it just got to be the point where I was having to work too hard to take home a paycheck. And when you're paying $1 million in overhead a year, that's a hard pill to swallow. So you start looking at other opportunities. So it was one of these things that just kind of fell into my lap. They were looking to expand out to a community hospital that I was already working at. It was a good transition to where I could take my practice with me, work at the same hospital, and then add residents onto it, make a salary and get rid of the trauma call and really improve my quality of life. So that was really why I did that.
So I did, when I came to Atlanta, I immediately affiliated myself with Emory and became an adjunct professor there. And I would take residents, and they really didn't have a shoulder person. And it took them about 7 years or so to figure out, hey, we need a shoulder person. And then they started rotating their residents, their senior residents, through me because of that, just because of the relationship we'd maintained. And so they were very helpful in terms of research projects and keeping you stimulated academically. They've since gotten shoulder people and brought their residents back in. And then we have a non-university based program in town too, Atlanta Medical Center. So now they rotate their residents through us to get their shoulder experience. I think the thing that really makes the biggest difference is that nowadays groups are required to gather data just for insurance purposes. And so you probably have somebody in most big groups whose job is to look at all the patient-reported outcomes, and those kind of people can really get your research going for you and help you set up the platforms you need, OBIRD or whatever it is, to collect your data. And so when you're looking for a practice, I would look to see what sort of structure they have around research, because it really takes people. Like you heard Spence mention a couple times how valuable his research assistant's been to him, because there's just so many hours in the day. So I think you need to have structure around you, so people taking care of things for you, because you can't do it all. Ian, what are your thoughts?
Yeah, getting assistance is great. I mean, early in practice, you'll never have more time. I mean, during the clinical week, it's not going to be full of patients and surgeries. So I would encourage you to use some type of data collection system early on so that it becomes a habit. And being a part of ASES, you have access to a couple of options at either a heavily discounted or free rate. Another way to do it is staying involved. Like you said, I mean, I still work with some of the residents at Vanderbilt, even though I'm no longer there. And then also industry can give you an option for research. And it's, you have to make sure you're not looking at it through rose-colored glasses, but there are ways to utilize your industry contacts to get involved in some projects, which is mutually beneficial, I think.
Spence, it seems like you got a pretty good setup up there.
Except for his internet, I guess.
So,
yeah, my internet connection's kind of gone off. Can you guys hear me now?
yeah, we can hear you now.
Okay.
Seems like you're pretty well
All
set
right.
up
So
there.
about 5 years ago is when I got a research assistant. Before that, I was struggling to do it on my own. It was really, really hard. But getting that person made a big difference in being able to get IRBs through and stuff like that. But there's a lot of collaborative efforts that happen through the Shoulder Society. And now that we've got candidate membership and stuff like that, you can get involved in multi-center research projects where you can get published. And anytime anyone asks you to go give a talk, back when we used to give a bunch of talks at Rosemont, anytime someone said, hey, can you come give it? Yes, I'll come give that talk wherever. It gives you experience. It gives you the opportunity to collaborate with other people. Hey, I've got this idea. I'm thinking about doing this research. That way you're not doing it all on your own. It's through other people. And so it's so important to collaborate with other surgeons across the country.
Yeah, I think the private-demic model is growing. And so, if you want to do basic science research, you need to be in an academic institution. But if you want to do clinical research, there's a lot of opportunities to be doing that, even in the private practice setting. So I want to go back to one thing we talked about. We started talking about sports teams for a little bit and sort of got cut off there. But, I can tell you that there's advantages at every single level, from the pros all the way down to college and high school. But, when you take care of a professional team, you're the babysitter for the team. And then when a player needs surgery, they go, oh, I want to go see Jimmy Andrews, or I want to go, to LA or to New York. And so, it's a little frustrating that you don't really get to operate on those, major league or professional, all-star players. but you do get a name for taking care of the team. And so you'll wind up seeing players, at all levels who play those sports that can be helpful. But the benefit of a high school team, like you've heard multiple times tonight, is the fact that high school parents tend to be in their 40s, and they are hitting the first time in their life where they're starting to have aches and pains in their joints. And so who are they going to look for in terms of finding an orthopedic surgeon? They say, well, Dr. Byram takes care of the school team. He must be good. And so you get referrals like that, you get the whole family. So it's not just the student, but the parents, and the parents are really looking for a doctor for the first time. And so that's one of the reasons that level is so sought after, and why so many people are going after, the high schools, even though you think it's not as prestigious as some of the higher levels, but in terms of filling your practice, it's a lot better.
There's also baseball academies, basketball, AAU, and all that stuff that you can tap into, and you can be the preferred orthopedic surgeon for those specific sports. And that's been a wonderful avenue for me. So something to consider, just tapping into all those outside of high school sports, but those guys are really, really high level.
So as we close up tonight, I have a final question for the panelists from one of the fellows. How do you balance offering new and relatively unproven procedures to help build up a niche while sticking with research-based practice, which is tried and true?
Randy, why don't you start on that one?
Yeah, again, I think you want to have evidence base behind anything. I don't think you just want to go and do experimental things on it. You want to make sure that you have offered all of the appropriate treatments and there's really nothing else left. And if there's, reports on some particular technique, I mean, I guess you're talking about things like superior capsule reconstruction, or maybe balloons, or those type of things. Is there anything else to offer that is more mainstream or not? And if there's not, and you are the guy and you probably had training in it, what is that behind them? But you got to be honest with your patients, and you got to sit there and say, this is what it is. This is a new technique. There's not long-term data. This is what the short-term or mid-term data is going to be, and be honest with the patients so they can have a realistic expectation for the result.
Ian?
Yeah, I mean, I think being as honest as possible, which this isn't per se the question, but sometimes people will ask you how many of these have you done, things along those lines. And you don't have to come out and give a number, but you can say, I do more of these than anybody else in the group, or something along those lines. But you got to be careful, because if you come out guns blazing and you're the only one doing stem cells for, radiocapitellar arthritis, people are going to have, they're going to form their opinion about you. So you got to ingratiate yourself to your own group, the community, and your patients. So I would err on the side of not being, over the top early on. But again, that's stylistic, and everybody's got to figure out their own path.
Yeah, I think that, your practice is going to be in growth. I mean, you're being trained at a point in time right now, and the way you're going to be practicing 10 years from now is going to be very different. And the same goes with all of us. I trained in open rotator cuff repairs, and so we've obviously evolved to doing everything arthroscopically. Well, how did that happen? Well, you do baby steps towards getting there, and you're trying to do what's best for the patient. And so I think some of the things you have to think about are techniques and evolution. And then other issues are unanswered questions. And so for the longest time, I was the end of a big funnel where I got all these 50-year-old guys with massive irreparable rotator cuff tears. And I was so frustrated about what to do for it, because there was no solution. And so I kept looking for a solution. And then, superior capsule comes along, the lower trap transfer comes along, and those are new techniques. And when they first happen, they're new, and you don't know for sure what the long-term results are going to be. So I think you have to dip your toe in the water and be very cautious about how you do it, and then study what you do and report what you do. Even if you're trying a crazy thing that wind up not working, you're the one that said, hey, don't do this. I tried it and it didn't work, and you reported on it, you'll still be respected for that.
Yeah, one other thing, I would consider talking with one of your senior partners and leverage their experience, leverage their reputation, and consider working with them on some of these things so that it's not just you out there doing that, but working with someone that maybe could coach you a little bit with their experience as well.
That's great advice.
So thank you, everyone. Thank you for your contribution in the hour. It was an amazing session. We appreciate everyone's time and efforts, and stay safe. We'll see you next week for the next installment.
Great. Thank you all.
Thanks, guys.
All right. Good night.
Bye.
Night, guys.